Good morning, everyone. My presentation will be on MRCP, and it's basically a primer for residents how we approach MRCP at our institution. So the principle of MRCP is that fluid-filled structures in the abdomen, they have a long T2 relaxation time and they appear bright on T2 weighted images. MRCP utilizes heavily T2 weighted images in which the increased signal is obtained from static slow moving fluid in the biliary and pancreatic ducts. So the basic sequences that we used for MRCP are essentially two, which is the 2D radial MRCP or the 2D thick slab MRCP and the 3D coronal oblique MRCP images. We usually also acquire axial, coronal, and sometimes sagittal T2 weighted images. Additional sequences that we can acquire are the Fiesta sequence in case of GE or the Profi in Siemens and the BTFE in Philips. And diffusion weighted imaging and sometimes T1 weighted images are also required. So the radial thick slab, that is the 2D thick slab images, generally they consist of their breath hold sequences, short breath hold sequences for about say 2 to 3 seconds. You can acquire one radial slice. For that much time you require the breath hold, and these are acquired in about 5 to 8 slices or more can be acquired, each of about 40 mm thickness, and they are acquired in multiple vertical planes with the center on the CBD. So you get rotated images of the CBD and the pancreatic ducts. Then the other sequence is the coronal oblique MRCP. This is acquired in a coronal oblique plane, and it's a kind of a volume acquisition. It takes about 3 to 4 minutes to acquire, and this can you can actually do 3D reformatting in these images. The other sequences which we acquire generally T2 weighted images in multiple planes, and sometimes we use this Fiesta image. This is in the GE machine. You can see that it provides an excellent contrast between fluid and other structures. And in this image, you can particularly see that you're not able to appreciate these calculi here in the distal part of the CBD properly, but you can appreciate them better on the Fiesta sequence. One other advantage or disadvantage of this image is that you can see the slow moving blood is also appears bright on these images. Here it appears as a flow wide. Then here you can see that we've given positive oral contrast to decrease the signal, bright signal from the stomach, but on Fiesta images, it appears as bright. T1 weighted images, we particularly look at the pancreas, which appears relatively hyperintense to the rest of the surrounding organs. And in disease pathology, particularly pancreatitis, you can see that hyperintensity is lost. So you can suspect some kind of a disease process in the pancreas. Diffusion weighted imaging, we generally try to look for masses or some other lesions associated with our biliary dilatation. So this is a case where you can see on the T2 there are multiple biliary dilatations. There's a small hyperintense image here, which is better, which shows which is bright on diffusion weighted imaging. Could be an abscess or it could also be a metastasis. In the same patient, you're seeing a subhilar block, multiple calculi in the GB, and the axial image at that section shows a diffusion restricting lesion in the GB fossa, which was suggestive of carcinoma gallbladder. So coming to the normal biliary anatomy, we generally have the CBD. We have the right and left hepatic ducts. The right hepatic duct consists of a right anterior, right posterior system, and they form the CHD. The cystic duct drains into the CHD and then forms the CBD, which is joined by the main pancreatic duct to form the pancreaticobiliary junction, which is generally intraduodenal, and that drains into the duodenum. So a number of anatomical variants are described. There are many classifications. The common ones I'm listing here. This is described by Huang. This is the common one that we see where the right duct is formed by the union of right anterior and right posterior ducts. Sometimes we have a trifurcation kind of pattern where right anterior, right posterior, and the left duct join together. This is also another common variant where we see the right posterior joining the left system. Occasionally, you have the right posterior joining the CHD separately. That is the Huang type 4. And sometimes we see the right posterior joining the cystic duct. So these are just MRCP appearance of a triple confluence. And this is the right posterior hepatic duct joining lower down into the CHD. Sometimes the right posterior hepatic duct can also join the cystic duct. So in this situation where the right posterior hepatic duct, it goes and joins the LHD, there may be problems where in cases of left hepatectomy, and you can see that there may be sectioning of the right posterior hepatic duct. So whenever we look at MRCPs, showing all these variances, listing all these variants is very important. Then there are variations of the left hepatic duct also. We don't usually describe them, but it is good to know these things. You can have a type A kind of variation where the common duct of 2 and 3 join the segment 4 duct, or you can have a triconfluence of all the segment 2, 3, and 4 ducts, or you can have a situation where the segment 2 duct will join the union of the common channel with 3 and 4 ducts, or you can have some unclassified patterns here. You can see that the segment 4 duct, 2, 3 are all joining together, and there's also an accessory duct. So there are also cystic duct variations. At least 3 of them are there. You can have a low cystic duct variation into the distal third of the CBD, generally joins the right side of the CBD. Then you have another variation where you have a medial insertion of cystic duct that goes and inserts into the left side of the CBD. And you can also have a parallel cystic duct which can run for more than 2 centimeters parallel to the CHD. So the clinical significance of these cystic duct variations particularly lies in case of lap cholecystectomy cases, in patients with like drainage of cystic duct into the left side of the CHD, or an aberrant RPHD draining into the CHD or into the cystic duct, or drainage of the cystic duct into the right hepatic duct. During lap cholecystectomy, there can be inadvertent ligature or section of these aberrant ducts, or the CHD may occur. So coming to the normal pancreatic ductal anatomy, we have the main pancreatic duct, which generally joins the duct of Wirsung. And the duct of Wirsung is the ventral pancreatic duct, which then joins the CBD to form the pancreaticobiliary junction, which has which is generally extra pancreatic or intraduodenal. Here you can see that this is the muscular sphincter around both the terminal portions of the CBD as well as the MPD, and they form a common channel which drains into the duodenum. Then there's also an excess. There's also the minor papilla, or the minor duct, or the duct of Santironi, which drains slightly cranially via the minor papilla. So that was the normal anatomy. We should know the variations in pancreatic anatomy. There can be a bifid configuration in with the dominant duct of Wirsung. So the dominant drainage here you can see is by the duct of Wirsung. You can have a bifid configuration where the dominant drainage is via the duct of Santorini. You can have an absent duct of Santorini, or you can have pancreas divisum where there is no connection between the dorsal pancreatic duct and the ventral pancreatic duct. Sometimes you also see cases of ansa pancreatica. In this situation, there's a small defect in the dorsal pancreatic duct, and it joins with a branch of the ventral pancreatic duct by a looped kind of S-shaped loop kind of configuration. So sometimes you also see variations in the course of the pancreatic duct. You can see a descending course, a vertical course, a sigmoid course, and sometimes you can also get a looped course. So a loop course is sometimes associated with pancreatitis. So it is important to see all these variations. And this is a kind of a vertical kind of course of the MPD, which we commonly see. Then pancreas division, this is one of the types of pancreas division. And what we commonly see is that we find that the main pancreatic duct drains here by the dorsal duct, and it is draining. It passes anterior. You can see in this axial image, it passes anterior to the CBD, and then it drains into the duodenum. So pancreas divisum can also have about 4 types. You can have a complete pancreas divisum where you have separation of both the dorsal duct and the ventral duct. You can have an incomplete pancreas divisum where there's a short connection between the dorsal duct and kind of an incomplete connection between the dorsal and the ventral ducts. You can have a reverse pancreas divisum where the dominant drainage is there's separation between the dorsal ducts and the ventral ducts, and the dominant drainage is via the ventral duct. Or you can have an absent ventral duct, and the entire drainage happens via the dorsal duct. Then ansa pancreatica, as I described already, ansa pancreatica, you have a small atrophic portion of the dorsal duct where it joins the ventral duct. And this part, the dorsal duct is generally joined to the ventral duct through one of its side branches through a kind of reverse S-shaped kind of loop. So this is the appearance, and you can see that this is the S-shaped kind of loop which is joining the dorsal duct. So ansa pancreatica, loop configuration of the pancreatic ducts, they can sometimes be causes of pancreatitis. That's why it's important to report them. Then there is a condition called pancreaticobiliary maljunction, which was described by the Japanese Society of Pancreaticobiliary Malformations in 2017. And 4 types have been described. So you can have a stenotic type of condition where you have a distal stenosis of the CBD, and there's upstream dilatation of the CBD. You can have a non-stenotic type where there's no stenosis of the CBD. You can have a dilated channel where there's a terminal narrowing of the CBD, slight narrowing, and there's a dilated common channel. The CBD may or may not be dilated, and you can have a complex type. This is generally associated with pancreas divisum or annular pancreas. So the importance of these, the common channel in cases of pancreaticobiliary malformations is always prolonged. Some authors say that it should be at least more than 15 mm to call it a pancreaticobiliary maljunction, while others say that an 8 mm length is more than enough. And the important reason why we encounter some kind of many cases where we are always in doubt that what is the cause of this CBD dilatation. So it has been shown that pancreaticobiliary maljunction has been associated with type 1A, 1C, and type 4A choledochal cyst. So this is a normal pancreaticobiliary junction, and this is a situation which we commonly encounter. You look at middle-aged individuals coming sometimes even with post-cholecystectomy situations, but you find that the CBD is of relatively very large caliber, say more than 10 mm in diameter, and you don't know what could be the cause of this condition. You could say that there's a lower CBD stricture, but what is the cause of this condition? So we should try to look at the pancreaticobiliary length of the pancreaticobiliary junction, and in this case, that you can see that it's relatively prolonged. So this is a kind of a, you can check, this is kind of a stenotic pancreaticobiliary junction. So at least you are able to explain the cause, and this will be the precursor like of type 1 choledochal cyst. So we'll just discuss some common pathologies on MRCP. So this is the classification of choledochal cyst. This is the one which I like to look at most of the time. So there are 1 to 5 choledochal cysts, and the type 1 choledochal cyst is divided into type A, type B, and type C. The type A is a kind of cystic dilatation of the extrahepatic bile duct. Type 1B is kind of a focal dilatation, focal segmental dilatation of the generally of the distal CBD, and type 1C is a fusiform dilatation with of the entire CBD with some amount of intrahepatic extension into the central ducts. Type 2 is a kind of a diverticulum from the CBD, and type 3 is a choledochal seal, which is an intraduodenal dilatation of the terminal portion of the CBD. Then type 4 is divided into type 4A and type 4B. So in type 4A choledochal cyst, you will find that there's an extrahepatic dilatation of the CBD as well as multiple dilatations of the intrahepatic portion of the bile duct. In the 4B, you have only multisegmental dilatation of the extrahepatic bile duct. Type 5 is a classical multiple only intrasegmental dilatation of bile ducts, which is called the Caroli's disease. So just some images. This is a type 1A cystic dilatation. This is type 1B, which is a focal segmental dilatation of the lower CBD. Type 1C, as I said, once again associated with abnormal pancreaticobiliary junction. This is a long common channel, and you'll find fusiform dilatation of the entire CBD and some prominence of the central ducts. So type 2 choledochal cyst, it's like a diverticulum. So here you can see the axial weighted images. This was not acquired as an entire MRCP. You can see there's a small diverticulum anteriorly from the CBD. This is the post-contrast image in the sagittal section. You can see there's a small outpouching here. When we run this image, here in the lower part of the CBD, now you see a small diverticulum which is connected to the lower part of the CBD. So type 3 choledochal cyst is a very rare anomalies, and this is one situation which we encountered here. You can see we had only a CT to show this. We confirmed this intraoperatively. Here you can see the lower end of the CBD is slightly prominent, and then this passes into the pancreaticoduodenal groove and then into the duodenum. So you have an intracystic intraduodenal dilatation of the terminal portion of the CBD. Type 4A choledochal cyst, extrahepatic plus an intrahepatic dilatation. Intrahepatic dilatations are generally multiple. Caroli's disease, we have multiple intrahepatic dilatations of the intrahepatic biliary tree. Generally, the CBD is normal. So Caroli's disease, it can be segmental also and can be unilobar also. So this is one situation where you're seeing that largely the dilatations are confined to the right side of the biliary system. And on the CT, you can find that there is a small enhancing radical, which are portal venous radicals within the dilated bile ducts, which is called the central dot sign. So there's an entity called the type 6 choledochal cyst also, and this is an isolated dilatation which involves only the cystic duct. So you can see that the gallbladder appears normal as well as the rest of the biliary system appears normal. So an isolated dilatation of the cystic duct is called a type 6 choledochal cyst. Then common abnormalities that you encountered, cholelithiasis and choledocholithiasis. In the distal CBD, calculus can appear show as a convex upward directed meniscus. Then we have benign biliary strictures, which we commonly see And we use, the malignant biliary strictures, and we use the Bismuth-Conrad classification for these strictures. A type 1 stricture is just a subhilar stricture. A type 2 stricture involves the confluence of the hepatic ducts, and a type 3A stricture involves the CHD confluence as well as extends to the right secondary confluence. A type 3B stricture involves the CHD confluence as well as the left secondary confluence, and type 4 stricture involves the CHD confluence as well as both the right and left secondary confluences. And MRCP, generally in case of malignant strictures, we are asked for to evaluate for the ductal separation, the number of ducts that are separated. The endoscopists or the intervention radiologists generally need to see these images to assess these conditions. So here in this condition, we are seeing a type 3A stricture where the confluence is involved as well as the right secondary confluence is separated. Here in this situation, you're seeing a type 1 kind of subhilar stricture. There's a calculi in the GB, and this was the diffusion weighted image. It shows a mass in the GB. So whenever, most of the time, surgeons as well as we are often looking at our 2D thick slab images. So in this thick slab image, you can clearly see that this is a portion of the left hepatic duct, this is the right anterior duct and the right posterior duct. Here you can see them separated, but when you rotate them, there will be some plane where you'll find that these ducts don't appear to be separated. So the clue to this issue is, like, whenever you are evaluating these images, you can see they are not separated here, but as you turn the image around, when you find one plane at least where you can see there's a separation between these ducts, so you can say that these ducts are separated. Then adenocarcinoma of the pancreas generally appears as a pancreatic head mass, and it's a T2 hyperintense region, usually shows diffusion restriction, T1 hyperintense, and shows mild post-contrast enhancement. And in the MRCP, typically you see a double duct sign, that is a dilated MPD as well as a dilated a CVD. And coming to benign biliary strictures, we use generally the Bismuth classification, and it is a type 1 stricture if the length of the CHD is more than 2 centimeters. Type 2 stricture, the length of the CHD is less than 2 centimeters. Type 3, if the floor of the confluence is involved but the roof is patent. Type 4 stricture, when the hilar confluence is completely involved. And a type 5 stricture, where you have an aberrant right hepatic duct, which is separated, which is involved along with involvement of the CHD. So this is a typical case of a type 5 biliary stricture. Here you can see the aberrant right hepatic duct separated from the rest of the biliary system as well as the CHD. Then we often find post-hepaticojejunostomy strictures. This is one case where you can see this is the jejunum, and you're seeing dilated ducts on both the right and left side with multiple interductal calculi. This is another case where you can see this is a loop of jejunum at the hilum. What you're seeing is that there's no dilatation of the right anterior system as well as the left ductal system, but you can see a dilated duct in the right posterior system. So this is the portal vein. This duct lies posterior to this system. This is segment 6, and you're seeing an interductal calculi. So probably in this situation, the surgeon failed to anastomose the aberrant right hepatic duct while doing the hepaticojejunostomy. So sclerosing cholangiopathy, we often sometimes see this condition also. So generally there are multifocal strictures which can involve the extrahepatic biliary system as well as the intrahepatic ducts. Generally you don't see significant dilatation, but the way to say that this is sclerosing cholangiopathy, you have to observe it carefully, is that you have to see a central portion of the duct which will be strictured, and the more peripheral portion will be slightly more in caliber as compared to the central portion of the duct. So it can involve both the LHD, RHD as well as the CBD, and you can have multiple intrahepatic dilatations as well. In chronic calcific pancreatitis, we are generally called to look for strictures and calculi. So the normal appearance is a dilated, grossly dilated main pancreatic duct, and you should see side branches to call it chronic pancreatitis. Here there's a meniscus which is seen here, filling defect seen as a meniscus. If you run this MRCP and axial T2 weighted images, here we can see a filling defect in the central part of the main pancreatic duct. Then sometimes we also have to report strictures. Here you can see multiple interductal calculi. You can see a segment of the MPD is not visualized, and this is probably due to a stricture. So in conclusion, MRCP is an excellent non-invasive method for evaluation of the pancreatic biliary disorders, and it provides visualization of the normal and variant anatomy of the pancreatic biliary tree. It helps for evaluation of benign and malignant biliary strictures for proper depiction of the level of block and ductal separation, and additional sequences like T1, DWI, Fiesta can help for better characterization of these lesions. Thank you.